Dear ladies and gentlemen, greetings from the Malaysian Obstetric Medicine Society. In conjunction with the World Neglected Tropical Diseases Day, which was actually the 30th of January 2022, I think it's timely to revisit another neglected topic, which is neglected tropical diseases in pregnancy. So, ladies and gentlemen, I would like to declare that I've got no conflict of interest in this talk. So let's revisit again, ladies and gentlemen. It was just yesterday that the world celebrated the World Neglected Tropical Diseases Day. And hence, I believe it is extremely important to revisit this topic, especially with regards to neglected tropical diseases in pregnancy. As much as we have appreciated that the world has been infected by the Facebook virus, where there are billions of users, let's not forget that throughout the world, about a billion or 1/6 of the global population are actually affected by the neglected tropical disease. It is not COVID which has been in the limelight for the last 2 years, but let's not forget other neglected tropical infections. And hence, I believe this topic is extremely vital. So, what are the neglected tropical disease? It is defined as a group of preventable and treatable parasitic, viral, bacterial, fungal, and non-communicable diseases that actually, as I mentioned earlier, affects 1/6 of the global population, out of which a significant number of them will be in the reproductive age group, out of which a significant of them will be or will soon embark in a pregnancy. So, what are the neglected tropical diseases? You can divide them into 4 groups. Those protozoa-related diseases like Chagas disease, Leishmaniasis, human African trypanosomiasis. The virus, especially prevalent in Malaysia, dengue and chikungunya. Let's not forget rabies. The bacterial infections, the Burulai ulcer, leprosy, trachoma, and yaws, and the helminth-related infections, especially schistosomiasis infections. So with regards to this talk, ladies and gentlemen, although it is neglected and the topics are wide, I would like to focus your attention to 2 conditions: dengue in pregnancy and schistosomiasis or hookworm infestations in pregnancy. So with that, ladies and gentlemen, let's first take a look on dengue in pregnancy. I'm sure every one of y'all in this webinar are experts or have seen or have managed. But believe me, ladies and gentlemen, what we know with regards to dengue in pregnancy is merely the tip of the iceberg, and I will define and I will discuss the controversies, and perhaps we can come up with a management plan of how to approach a lady who's got a dengue infection in pregnancy. So let's first take a look at the overview with regards to dengue. I'm going to talk about the implications of pregnancy on dengue. I'm going to talk about the implications of dengue on pregnancy. We often engross with platelet counts. We often engross with the number 50, with the number 80. I'm going to prove to you all that there is no one magic platelet number with regards to infection. So be cautious about platelet dysfunction, be it any infection, be it COVID, especially dengue. I'm going to share with you all with some lessons learned from the confidential inquiry evaluating mothers who have died from dengue. I'm going to highlight the risk of vertical transmission, especially if the mother is positive, and why you should not deliver a mother who's dengue positive during the febrile state. Ladies and gentlemen, if we have appreciated the fact that 1 billion global population are infected with neglected tropical diseases, let's appreciate the fact that almost 1/3 of the global population live in the dengue belt. And this includes African nations, Southeast Asia countries, South and Central America, the Caribbean countries, and the Pacific countries. So although we know and we believe that the COVID originated from Wuhan, we also know that the Aedes aegypti mosquito actually originated in Central America and in Southeast Asia. But how did this mosquito, who can only travel 400 meters, can spread to half of the world? It is actually complicated. It is actually promoted by the industry, namely the tire industry. So when we started globalization, when we started the industrial revolution, tires were actually transported from Southeast Asia throughout the world, and tires stored water. The mosquito larvae in this tire actually spread across the world. So ladies and gentlemen, development, globalization, and the tire export contributed significantly to the spread of dengue throughout the world. So having appreciated that, it is still the most rapidly spreading mosquito-transmitted disease, or known as vector-related disease. Although we are focused on COVID, let's not forget the implications of dengue in pregnancy. There has been a 30-fold increase of dengue infections and mortality in the last 50 years. Annually, 20,000 deaths related to dengue. It is still prevalent. It is not spoken about, but it still happens daily. So let's take a look at the dengue virus. It is a single-stranded RNA virus. It belongs to the genus Flavivirus. There are 4 serotypes, 1, 2, 3, and 4. Although there were case reports that a 5th serotype was actually isolated in the Borneo Islands, we now believe that there are no 5 strains, there are 4 strains. And the Asian genotype is known as the dengue strain 2 and the dengue strain 3. Now, why are they important to know which strain is infected? It is actually the combination of strains that causes more harm than a single strain, and what I shall highlight in the next few slides. So if we were to find a dengue vaccine, the challenge of the vaccine is that it has to be effective against all 4 strains, and that remains one of the significant challenges with regards to the dengue vaccine. So having appreciated that, it is not like COVID, where the first infection causes harm. In dengue, it is actually not the first infection, it is actually the secondary infection. It is actually the secondary heterotypic infection. So if you live long enough in a dengue-prone area, chances are that you would have been infected the first time, you would be well. But it's the second dengue infection that causes significant harm. And going back to the strains, the lethal combination is to be infected with dengue strain 2, followed by dengue strain 1. And this combination causes severe dengue. The second risk factor is a time interval of 20 years. So the longer you live in a dengue-prone area, the higher the chance of you having a secondary infection, the more prone you are for a severe infection. So similarly, infants of mothers who are already positive have already got the primary infection even before birth. And then in their adulthood or later on in their life, if they get the secondary infection, they are at a higher risk of severe dengue. Now, COVID, we often talk about the cytokine storm, but in dengue, the pathogenesis is different. It is now appreciated as an antibody-dependent enhancement. And various patients with various antibody-dependent enhancements causes and predisposes them to get severe dengue infection. So ladies and gentlemen, the take-home message, it is not the first infection, it is the secondary infection, and the lethal combination is strain 2 followed by a strain 1. So having appreciated that, let's appreciate the factor. It is actually an Aedes aegypti and Aedes albopictus. There are two strains. The mosquito only flies 400 meters. So ladies and gentlemen, a significant host is not the mosquito, but human beings. The mosquitoes are found in households. The mosquitoes are found in supermarkets. The mosquitoes are found in high-rising apartments because humans transmit the mosquito, and hence the mosquito and the disease is transmitted. The breed indoors, eggs remain viable for months without water, hence the hypothesis of the tire industry of how it has disseminated this virus across the globe. Bites often occur commonly in the mid-morning, the late evening to dusk, and that are some essential facts about the vector. Now, dengue can be classified into 3, and the WHO actually took in hand the expert group Geneva classification. In the past, we used to categorize them differently, but after 2018, we can classify dengue into 3. Dengue without warning signs, dengue with warning signs, and severe dengue. So what are the warning signs of dengue? Abdominal pain with tenderness. Now, it is not every patient who comes with labor pain. So one has to differentiate contraction pain with abdominal pain. These are 2 different signs. Not all pregnant mothers are hyperemesis gravidarum. Vomiting and fever is the red sign for dengue for COVID. Also take a look at fluid accumulation, mucosal bleeds, mothers who are lethargy. This used to be a predominant sign. And other signs like liver enlargement and increase in hematocrit are part of the warning signs. But please remember, the criteria for severe dengue is plasma leakage, hemorrhage, and organ involvement. And the 3 organs, the heart do an ECG, the liver look for a rising in AST, and the brain so monitor GCS. So the heart, the liver, the brain are 3 organs that you should be monitoring because this may be affected in severe dengue. It is not just the platelet count. So ladies and gentlemen, the diagnostic criteria is simple. The gold standard remains hemoagglutination inhibition tests. But everyone's favorite test, dengue IgM. It is highest and most specific between day 5 to day 7 of fever. So if you do it too early, it might be negative. But please remember, dengue IgM, unlike COVID, may persist up to 90 days. So if the patient has got fever, think of COVID, which is here to stay. Think of dengue, which remains endemic. A negative test does not exclude dengue. A positive test does not confirm an acute infection. Now, IgG can be found if the patient has persisted illness beyond 7 days. The rapid antigen test, the bedside test, the NS1 antigen, actually detects non-structural proteins may drop at day 4 to day 5 illness. So do not be too engrossed with the NS1 antigen. It may be positive if you pick it up early. It may drop at a later stage of an infection. And other diagnostic testing is the rapid PCR and of course, viral isolation. So the take-home message, ladies and gentlemen, it is good to go based on clinical circumstances. Every single test has got its own sensitivity and specificity. The NS1 is a rapid diagnostic test, but it's only sensitive for the first 5 days. The dengue IgM may be positive up to 90 days. And please appreciate these facts before you actually interpret some results. So moving on, ladies and gentlemen, as obstetricians managing these patients, you can divide them into 3 stages. The febrile stage is when most patients will present with. They would be dehydrated. The hematocrit counts may still be low. The platelet counts may be normal. This patient needs to be given fluids and you need to give supportive care. But a critical phase is between 24 to 48 hours when the fever stops. And this is when they should be closely monitored. This is when the hematocrit goes up, the platelet count comes down, the patient has got a significant risk of bleeding. But ladies and gentlemen, as mentioned earlier, please do not be engrossed with platelet alone. Please monitor the liver function test. Please monitor the heart rate because some of them may have myocarditis. So ECG is important. Please monitor the CNS manifestations. And once the patient is past the critical stage, ideally 24 to 48 hours from a febrile, the patient is now in the recovery phase. In the febrile phase, more fluids. In the critical phase, watch closely. In the recovery phase, reduce the fluids because the patient now will have reabsorption of fluid. The patient may develop effusion of the lung, ascites, so do not abuse fluids. So management of dengue depends on which state you are. All 3 stages management differs, but please do not be happy in the critical phase when the patient needs to be observed closely, especially inpatient, where we believe that all patients who have got dengue infections in pregnancy, with or without warning signs, should be monitored and observed inpatient, especially in the critical phase. So having appreciated that, what are the implications of dengue in pregnancy? So ladies and gentlemen, there's been huge systematic reviews and meta-analysis, and now it is clear that based on this large systematic review and meta-analysis, there are significant implications with regards to dengue in pregnancy. So to the mother, it causes severe infection. Just like malaria, just like influenza, just like COVID, dengue may cause significant infection to the mother. There's a significant increase in mortality and morbidity, especially if the mother gets an infection in the 3rd trimester. Because of the platelet dysfunction, because there's increase in interventions, the incidence of PPH is increased. So ladies and gentlemen, if you have got an ill mother, you have got a mother who's dengue positive, try not to intervene in terms of obstetrics unless there are clear benefits. There are some benefits of delivering a COVID mother to aid ventilation, but there are no benefits to deliver an ill mother who's dengue positive because the risk of PPH is higher. And of course, cesarean section and operative deliveries are increased. So the take-home message, try not to deliver a dengue positive mother, especially in the first 10 days. Now, what is the risk to the fetus? Just like any inflammation and any infection, the mother's unwell, there's a preterm delivery increase. Just like any infection, the hypoxia, the acidosis can cause IUGR at stillbirth. The mother gets dengue in the 1st trimester. Because of the inflammation, there's an increased risk of miscarriage. But unlike Zika, dengue and COVID does not cause congenital abnormalities, but there's a risk of congenital dengue infection, where the fetus has got up to 25% chance of a vertical transmission. So another reason not to deliver a dengue positive mother is to reduce maternal risk of bleeding. It's also to reduce the fetal risk of transmission, because the risk of congenital dengue infection is as high as 25%. And of course, that baby who's just been born, who's positive, later on in life has got a risk of having severe dengue because the baby already has got infection, number one. Ladies and gentlemen, does dengue cause miscarriage? Yes. Based on the same study, if a pregnant mother is positive, is in the first trimester, she's got a 3.5-fold increased risk of having a miscarriage. Does dengue cause preterm birth? Yes. If the mother is unwell, if the mother is significantly has got with warning signs, has got severe dengue, the incidence of preterm birth is between 1.7 to 2.5 odds ratio. Does dengue cause low birth weight and IUGR? Yes. The odds ratio is between 1.4 to 1.84. And this is unlike COVID, where it does not cause significant IUGR, but more of SGAs. Although, if you get COVID early in the pregnancy, there are associations with preeclampsia and IUGR. Similarly, dengue does correlate with IUGR. So mothers who have recovered from dengue in pregnancy needs to be closely monitored, especially with growth scans. So what are the other pregnancy outcomes? Based on this systematic review, there's an increase in cesarean delivery, which is iatrogenic, which is because of an increase in intervention and concern, which has got no maternal benefits. And of course, because of the inflammation, there's an increase in preeclampsia and eclampsia, which are all direct consequences from dengue. So, ladies and gentlemen, what is reassuring about dengue? Unlike Zika, it does not cause congenital malformations. So in this state, dengue behaves like COVID. There are preterm delivery, there are miscarriages, there are vertical transmissions, but dengue does not cause congenital malformations unlike Zika. Having appreciated the implications of dengue on pregnancy, what are the implications of pregnancy on dengue? So, ladies and gentlemen, what are the challenges in pregnancy? Every pregnant mother, there's a 10% increase in heart rate. Hence, if you monitor a mother's pulse rate and you use it as a warning sign, it may be challenging, and hence, it is quite difficult to appreciate warning signs of dengue. There's an increase in white pulse pressure in a pregnant mother, especially in the second and third trimester. Hence, it is quite difficult to appreciate pulse volume. It's difficult to detect third space loss in a pregnant mother, especially in the late second and third trimester. Hence, it is difficult to diagnose ascites, effusions to palpate the liver. It is difficult to appreciate liver tenderness. The white cell count of up to 19 and 20 can be normal in pregnancy. Hence, please do not diagnose leukopenia, because even if a pregnant mother has got a white cell count of 12, that may be considered low in pregnancy. And don't always expect a pregnant mother to have a very low white cell count. We are often engrossed with hematocrit. We are often engrossed with the number of 30 and 35. But ladies and gentlemen, there's an increase in plasma volume in pregnancy. There's a physiological dilution. So a number of 30 may be significant in a non-pregnant mother, but a number of 30 is extremely significant if she's pregnant. So do not be engrossed with hematocrit. Please appreciate physiological changes and dilutions in pregnancy. We often engrossed with platelet. I'm going to prove to you all in the next few slides there's no correlation between platelet number and platelet function. Any pregnant mother, the risk of platelet dysfunction is high. Monitor the liver, monitor the heart, monitor the GCS as mentioned earlier. And often we are engrossed with VBGs. Please remember, a pregnant mother has got a physiological hyperventilation. So the PCO2 counts are lower in pregnancy. There's an increase in EGFR, so the bicarbonate counts are also lower in pregnancy. It is good to appreciate all these changes before you can actually manage, diagnose, appreciate warning signs, and manage a pregnant mother with dengue pregnancy. So having appreciated that, it is also important to differentiate between pregnancy, between HELLP syndrome, and between dengue. Usually, of course, pregnant mothers with fever think of COVID, think of dengue. We even had a pregnant mother who had both at the same time. The incidence of PPH is extremely high among dengue patients because of the platelet dysfunction. But how do you differentiate between HELLP syndrome and dengue? For one, although we appreciate leukopenia, it is often not present. But the incidence of platelet dysfunction and the absolute platelet number will be far lower among patients who are infected as compared to patients with HELLP syndrome. But the one diagnostic criteria is the presence of hemolysis, which is pathognomonic for HELLP syndrome. So although we recommend various different clinical and biochemical parameters, if there's evidence of hemolysis, if there's high blood pressure, if there's no fever, think of HELLP. If there's fever, if she's been unwell, if there's no hemolysis, if the platelet is low, if the hematocrit is increased, think of dengue. But it remains a diagnosis of exclusion. In all patients with thrombocytopenia, it's important to exclude hemolysis by doing an LDH or a retic count or a full blood picture. And hence, a full blood picture is extremely important in such patients. Now, having appreciated that, let's appreciate one important fact that I would like to highlight: the association between platelet counts and platelet function. So, ladies and gentlemen, let me tell you a true story, a Kesa Berna. A 33-year-old multi was 36 weeks pregnant. She presented to us with a 5-day history of fever, oral intake, vomiting, and cough. And of course, we have excluded COVID-19. She was slightly tachycardic, which may be normal in pregnancy, but she had a significant spike of temperature of 38.6. Her white cell count was low. Her platelet was not actually a constant, it was 111. Her bicarbs was 16.2, her NS1 was positive, her lactate was low. So it is normal to check lactates for every single pregnant mother who presents with fever. It is a marker of hypoperfusion. The lactate is above 2, be concerned. Above 4, she should ideally be in ICU. So with these classifications, with this presentation, she was diagnosed with dengue with warning sign in the febrile phase. So she was admitted to ICU for close monitoring. Over the course of 3 days, her white cell count hovered between 3.8 to 7.9. But because she was in the febrile phase, her platelet dropped to 52. Now, many physicians, many obstetricians, and many anesthetists will not be too engrossed, will not be too worried with the number of 52. But today, at 52, she complained of severe abdominal pain. So for obstetricians in the crowd, not all abdominal pain is labor pain. So she was reassessed at that moment of time. There was tenderness in the right iliac fossa. The shock index was 0.5. A repeat platelet count was 44. Can you all tell me what is the diagnosis? Well, ladies and gentlemen, the diagnosis is actually she had a right-sided subrectus hematoma. So 2 days later, the patient who complained of pain actually was not in labor. How do we know that she was not in labor? We actually did not just do a vaginal examination. We did a cervical length measurements. and a cervical length measurement of above 1.5 negates labor. And we were reassured that she was not in labor. So please do not give her DEXA. Please do not never always tokolize a pregnant mother who's ill with an infection in ICU. Most of the time, when she complains of abdominal pain, it is a warning sign. It is often not labor. It is important to have a senior person to assess her to exclude labor. But it's important to think of other causes. And here we diagnose an intra-abdominal bleed. So we went in for an urgent laparotomy. We were convinced it was not labor. And intraoperatively, she had a huge subrectus hematoma with a right retroperitoneal hematoma of 10 by 10 centimeters. We did a cesarean section in the same stage because she was a term. To deliver the baby or not to deliver the baby, it's controversial. But since she was term, since we already subjected her to a laparotomy, we delivered a healthy baby of 2.9 kilos. The platelet was 323, but the blood loss was 1,000 mils. So, ladies and gentlemen, the point that I would like to highlight is that she had a subrectus hematoma, even at a platelet count of 44. This was not the first and only case of subrectus hematoma or intracranial hemorrhage or intraperitoneal hemorrhage. There's also a mother who died in 2012 with a similar subrectus hematoma, and the platelet was hovering around 25. So the point that I would like to highlight, ladies and gentlemen, do not be engrossed with the number. The platelet dysfunction is significant, especially if a pregnant mother has got an infection, especially if the pregnant mother has got dengue. So I'd like to highlight that platelet counts are not predictive of bleeding complications. The platelet dysfunction is high, and be concerned and think of bleeding, especially if it drops below 20. So ladies and gentlemen, if you've got a mother who complains of pain, please exclude intraperitoneal, intra-abdominal bleeds. If she's pregnant, the counts are dropping, make a decision on when to transfuse platelet. Please don't just wait until it drops to a single digit, or please do not wait until she's got bleeding tendencies. The management of a pregnant mother, the platelet dysfunction in a pregnant mother is far more severe as compared to a non-pregnant mother. Usually we will intervene even if she's asymptomatic if a count drops below 20 in pregnancy. Having appreciated that, that is one point why we should not deliver a pregnant mother who's dengue positive, because the risk of bleeding is higher. Next, let's appreciate the risk of vertical transmission. Ladies and gentlemen, in COVID-19, if a mother is positive, there's up to 4% chance that the baby may be positive as well. We think that it is not a vertical transmission, but it is transmitted via direct contact, and the magic number is 4%. Now, what is the magic number? The mother has got a dengue in pregnancy. So I'm going to illustrate some images. And this is a pregnant mother who came to us having fever at term. And this is a classical dengue rash, which is islands of white in a sea of red, which is even more prominent in the back, in the extensors, and in the trunk. And of course, we confirm her to have dengue. It is not always lucky that you will be able to make a spot diagnosis of dengue, but here's one patient who had a classical rash. So, because of non-obstetric causes, we had to deliver her. And in day 3 and day 5 post-delivery, we realized that the baby started developing rash as well. And here are images of the baby's rash on day 3 and the baby's rash on day 5. And we followed the baby closely. The baby's rash got worse. This was the baby's image on day 6. And on day 9, the baby developed severe dengue infection with a significant drop in the baby's platelet count. The illustration here is not to illustrate the baby's rash, but to illustrate the important point that the baby may have a risk of severe infection if delivered too early. So I'm going to highlight to you all that it is extremely important to make a clinical decision on when not to deliver. And one important time is not to deliver an ill mother. It is not to deliver a mother who is in an infective stage, be it COVID-19, be it dengue, unless there's a clear indication to do so, unless there's a clear benefit to do so. So let's relook about one important study which was published by Prof. P.C. Tan in University Malaya. They looked into the prevalence, vertical transmission, and pregnancy outcomes among dengue positive patients. And in their cohort, they realized that the incidence of vertical transmission can be as high as 25%. So for every 4 mothers that you deliver between day 1 to day 10, there's a 1 in 4 chance that the baby may also be severely infected as well. So ladies and gentlemen, the risk of vertical transmission can be as high as 25%. So I would like to share some of the lessons learned having evaluated a 5-year outcome of all the mothers who died from dengue in pregnancy between 2009 to 2013, a paper which was published in the BJOC in 2017. So looking into timing of maternal death, similarly, just like COVID-19, most mothers died in the 3rd trimester. Now, this is not something which is just out of the blue. I believe there's a significant change in the mother's immunity, and most of the interventions happen in the 3rd trimester. Hence, mothers are most vulnerable to infection, be it malaria, be it COVID, be it dengue, in the 3rd trimester. If you've got a pregnant mother with dengue in the 3rd trimester, be worried. We looked into age. Interestingly, most of the mothers who died, sadly, were young, something that we should really try to prevent. We looked into comorbidities. Most of them were well and healthy. The only risk factors they had, they were all healthy and they only had dengue. So dengue in pregnancy has got no association with comorbidities, unlike COVID-19. The only risk factor was that all of them were pregnant. We looked into duration, timing of diagnosis and hospital stay. It took an average of 3 days of symptom to make a diagnosis. So we are not picking them early. We are waiting for biochemical results to rate. Think of COVID, think of dengue. Every potential pregnant mother should be COVID negative, dengue negative in the first instance of presentation. So we are not diagnosing them early. It took these patients 3 days to come to hospital. And we think that perhaps with earlier intervention, with earlier presentation, we could have improved outcomes. So we should educate all pregnant mothers. If you are having fever, do a home test for COVID-19, come to the hospital, exclude dengue. Fever is a red flag. Vomiting, diarrhea, abdominal pain is a red flag. You should seek a care. And all of them stayed for a period of 7 days, 7 golden days before their eventual death. A time frame where I think perhaps with correct intervention, you could have actually improved their outcomes. So what are the red flags of all those who died? All of them had fever. 1 in 2 of them had diarrhea, nausea, and vomiting. And only 1 in 10 of them had rash. So please do not be engrossed with the rash that I illustrated. Any pregnant mother with fever, with vomiting, with diarrhea, who's pregnant should be admitted. It is not AGE. It is a warning sign for COVID. It's a warning sign for dengue. These are red flags. So every time when I'm doing ward rounds, If I'm told that there's a pregnant mother who's admitted with AGE, with fever, vomiting, and diarrhea, or there's a pregnant mother who presents with preterm labor, with fever and vomiting, please assess the patient. That patient may have an infection with a warning sign. It may not just be a straightforward AGE, which is what being perceived by the junior doctor. So what are the clinical signs on admission? They had temperature, they had tachycardia, they had normal blood pressure on presentation, for 1 in 10 at petachia. So fever and tachycardia are red flags in pregnancy. So having appreciated that, only 1 in 3 of them had leukopenia. So ladies and gentlemen, leukopenia is an insensitive test because most of the mothers will have a raised white cell count in pregnancy. Only 7% had hemo concentration. So the current policy says that all patients with dengue with a hematocrit count of 40 should be admitted. But ladies and gentlemen, do not wait for a hematocrit count of 40. It is far too high in pregnancy. If a pregnant mother has got a hematocrit count of 35, that alone is significant because of the physiological dilution. So we need to change the criteria for admission. We need to change the criteria of intervention. Do not be engrossed with the number of 40. And do not be engrossed with thrombocytopenia. There's no correlation between platelet count and platelet function among dengue patients. So what are the key points, ladies and gentlemen? Think of dengue because only 1 in 2 of the patients who died had a suspicion of dengue. Majority of patients had a normal platelet count, so please do not be engrossed with the count. Dengue in pregnancy, they are high risk of mortality and morbidity. There's no correlation between platelet count and bleed. Any patient who's dengue positive, irrespective of the count, has got a risk of bleeding. It is important to assess her holistically. 62% of patients had a hematocrit of 35%. So please move away from the hematocrit count of 40%. You need to have a lower threshold for intervention among pregnant mothers. Do not be engrossed with leukopenia. The white cell count will be normal. And any mother with severe dengue, the incidence of fetal loss can be as high as 67%. But that does not mean you should rush in and deliver. It does not mean you should do a CTG and act on a CTG. The principle is the same. Resuscitate the mother, treat the mother. The implications of dengue on the health and bleeding is significant. Only deliver if there's clear obstetric and medical benefits. Unlike COVID-19, it is best not to deliver an ill mother or a dengue positive mother in the first 10 days. Diarrhea is a warning sign. Not all abdominal pain is a labor pain. It is good, it is important to have a senior personnel to assess labor. One important measure, it's not an internal examination, but it is a cervical length measurement. The cervical length is above 15 millimeters. It is highly unlikely to be in labor. Be cautious about tachycardia. Be cautious about temperature spikes. Hence, all of them should be monitored on an early obstetric warning scoring chart, not in the medical ward, not in the obstetric ward, not in the labor ward, but should ideally be in a high dependency unit. Measure lactates, measure shock index, which are all early markers for mothers who are well. Having appreciated that, I think it is timely to have pregnancy-specific guidelines. This pregnancy-specific guidelines should be talking about not to be engrossed with thrombocytopenia. Be cautious if the hematocrit is 35. Be cautious if the AST is higher than 35. Use pregnancy-specific PCO2, which drops in pregnant mothers. Use pregnancy-specific bicarbonates, which is lower in pregnancy mothers. and diarrhea and labor pain and vomiting are often missed in the labor ward. Tachycardia may not always be physiological. So it's important to make the right decision. Avoid delivery if possible, at least in the first 10 days from febrile illness. Hence, it's important to involve a senior obstetrician or a consultant in the decision making. Caesarean section is not the cure for all infections, and avoid caesarean sections if possible, because the risk of bleeding, hematoma is significant. Every abdominal plane do not give dexamethasone. It may cause more harm than good. Only give dexamethasone if you think the mother is in labor, a decision that I would think 10 times. I would not avoid steroids. Fetal monitoring is essential. The risk of fetal death is 67%. Platelet dysfunction is common. Do not be engrossed with a number. PPH prophylaxis is important. Breastfeeding is not contraindicated. If you were to deliver a dengue positive mother, the pediatrician needs to be informed. The baby needs to be monitored. The baby has got a risk of congenital dengue infection. My thoughts, ladies and gentlemen, to summarize the entire last 30 minutes of dengue, do not be engrossed with biochemical values. If you're going to resuscitate a pregnant mother, use the current weight, not her booking weight. How much of fluids, what treatment you give her depends on the current weight. What we need is a multidisciplinary subspecialized care. Such patients are often isolated in the medical ward or the infectious disease ward. We need a team to manage. The team should be a physician, an expert in dengue, a senior obstetrician, and an anesthetist. You need to make a combined decision. The baby needs to be monitored. Do not rush into delivery. In an acute abdomen, it is not always labor. It is not always contractions. Be vigilant of hemorrhage. So to conclude, ladies and gentlemen, severe dengue is associated with morbidity, PPH, preterm delivery, stillbirth, and miscarriage. It is important we use pregnancy-specific values, and we should educate and empower all non-obstetricians to use these parameters, non-pregnancy values, when we are managing pregnant mothers. White cell count of 4 may be low in a non-pregnant mother, or a white cell count of 11 and 12 may be low in a pregnant mother. Platelet has got no correlation with bleeding. A hematocrit of 40 is abnormal in a non-pregnant mother, but a hematocrit of 35 is severely abnormal in a pregnant mother. A pregnant mother has got a lower PCO2 or lower bicarbonate. Platelet counts are not predictive of bleeding. The risk of neonatal transmission is high as 25%. Do not rush into delivery. The right time is important to prevent, and we need to have preventive strategies. We do have COVID registries in Malaysia, in overseas, which has been initiated by the University of Birmingham, but sadly, despite being endemic, we still do not have a dengue pregnancy registry, something which I believe is important to initiate and establish, something which I've been trying to establish in the last 2 years. We need to have pregnancy-specific guidelines with dengue, because the management, the observation, and the interventions are far different in a pregnant mother. We need to have an individualized approach. Now that covers dengue in pregnancy. I'm going to move on to the second part of the talk, which is soil-transmitted helminths in pregnancy, which I think is the second most neglected tropical diseases in pregnancy. The WHO now recommends chemo prevention for all those who live in criteria where they are highly prevalent of anemia, where the incidence of anemia is beyond 40%, one of which is in Malaysia. And the second criteria for chemo prevention is when the baseline infection in the population is above 20%. So ladies and gentlemen, I believe the incidence of hookworm infestations in Malaysia is not 20%, but the prevalence of anemia in our population is extremely high. So the current WHO recommendations is to give these two cohorts chemo prevention, a single dose of either albendazole 400 milligrams or mebendazole 500 milligrams. Now, both of these medications are safe in pregnancy. They're not contraindicated, but the recommendation is to administer after the first trimester. So should you give every pregnant mother? My take is no. But if you give every pregnant mother who lives in a high cohort of population, you think there is significant risk, especially in the interiors of Malaysia, especially when the iron counts and the iron therapy do not increase with time. Think of hookworm infestations, screen and treat, and chemo prevent. Apart from hookworms, WHO has embarked on 6 other strategies to eradicate 6 illnesses, and they are lymphatic filariasis, blinding trachoma, onchocerciasis, or known as river blindness, schistosomiasis from the snail fever, small transmitted helminths, which I mentioned earlier, and guinea worm diseases. All 6 of them can be eradicated just by chemo prevention, the 2 medications mentioned earlier. So with that, the WHO now recommends massive drug administration, which is to give every single woman in the reproductive age group single chemo preventive measures, especially in cohorts where we've got high incidence of anemia or where there are high incidence of hookworm infestations with either albendazole or mebendazole, and it is the current WHO policy. There are various studies currently looking into the policy of deworming women of reproductive age group, adolescence and pregnancy. It may not be relevant to the entire population of Malaysia, but I believe it remains significant, especially in certain parts of the world. This was a policy. Think of deworming of high-risk group of patients depending on suspicion. You should look for one. You should treat. Treatment is safe in pregnancy. Having appreciated that, I think we should also know Wolbachia with regards to dengue prevention in Malaysia. Now, what is Wolbachia? Wolbachia is actually a bacteria which is often not found in the dengue mosquitoes. So this Wolbachia bacteria can now be infused among the male fetus, and this male fetus with Wolbachia are then released into the population. This male fetus later join together with the female fetus and produce eggs, but these eggs do not hatch, and hence these eggs do not actually infect dengue. So Wolbachia infused mosquitoes are now one important way of preventing dengue. Now this has been tried in Singapore, this has been tried in certain states in Malaysia. I believe this is one way forward to prevent eggs being hatched, to prevent the transmission of the female Aedes aegypti. It's one important strategy to reduce the mortality, the morbidity, and infection from dengue. This seems to be the way forward. Apart from that, we should also advise all our pregnant mothers, all, to have long trousers, long sleeves, especially during the time of severe risk of transmission, which is in the morning, which is dusk. The clothing can be treated with insecticide, especially permethrin. It is not contraindicated among pregnant mothers. The repellents to be used should be a special type which is diethylmethyltoluamide, DEET-based repellents. They can also sleep using pregnancy nets. And these are normal advice that you should be giving to all pregnant mothers. Next comes Dengvaxia. Now, everyone can appreciate the speed on how the world came up, raced with time, and came out with the mRNA vaccine. And I'm sure everyone can appreciate that in 2015, Dengvaxia or the dengue vaccine was actually produced by Sanofi. Now, it is not recommended in pregnancy because it is a live recombinant tetravalent dengue vaccine. It is a series of 3 doses given at 0 month, 6 month, and 12 months. There are phase 3 clinical trials of the vaccine. The vaccine shows to be harmful if the patient gets it and the patient has been dengue naive. But there has been some benefit, up to 52%, if the patient had a primary infection. So it is not still a routine policy. It has been advocated in certain countries. I believe that the global population will next focus on dengue while we have actually controlled COVID-19, because I believe that the vaccine is one important preventive strategy, especially with regards to saving lives. So as of now, ladies and gentlemen, it is definitely not recommended in pregnancy. It's important to watch the space. The vaccine is beneficial if someone already has got a primary infection. But the vaccine is not recommended if someone has never had a primary dengue infection in the past. So with that, ladies and gentlemen, I would like to summarize that tropical diseases are neglected, and the diagnosis of tropical diseases are often neglected during pregnancy. It's good to think about these rare conditions. Dengue and hookworms are not uncommon. It remains prevalent. The implications are severe. In high prevalent areas, you can actually prevent hookworm infestations. The WHO policy is to give pregnant mothers opportunistic albendazole and mebendazole. May not be a policy that you're going to advocate to all your pregnant mothers in Malaysia, but it is safe. It could be given, especially if you work and practice in a high-risk population where you think hookworm infestations are predominant. For dengue, do not just be happy if it's managed by a group of physicians. You need to manage in collaboration. You need to have a multidisciplinary team involvement. The obstetrician should appreciate physiological changes. You should know when to intervene. You should know when not to intervene. And ladies and gentlemen, with regards to rare, neglected tropical diseases, prevention is always better than cure. So with that, I would like to bring your attention to this video. So ladies and gentlemen, the MOMS Scientific Congress is happening in 4 months' time. We have limited on-site places available. if you are interested to know all about maternal medicine, if you are interested to know about the finesse, about the guidelines, about the controversies, and how best to manage high-risk pregnant mothers, I would strongly encourage you all to register now. We are just 4 months away and seats are extremely limited. So please come on to the website. Please register today. And I look forward to see all of you all physically at the World Trade Center on 20th to 22nd of May, which is just 4 months' time. So with that, ladies and gentlemen, I'd like to thank you so much for your attention. If you have any questions, I'll be more than happy to answer them. If you want to have more information and resources, kindly visit us at www.obstetricsmedicine.my. I look forward to meeting all of you all in person at the MOMS Scientific Congress 2022. Thank you so much for your kind attention.